Welcome, everybody. It's Dr. Linda from the Vascular Birthmarks Foundation. Welcome to today's Facebook Live session on vascular birthmarks. Today, I'm with world-renowned surgeon and vascular anomalies expert, Dr. Gregory Levitin from the Mount Sinai Hospital in New York City, and he also practices in California, in Los Angeles. And what is the name of the place in California?
Part of Cedars-Sinai Hospital.
Part of the Cedars-Sinai Hospital. We're very happy to be in New York today with Dr. Levitin, and we will be taking any questions. These are people all with their happy faces. Any questions regarding the diagnosis and treatment of vascular birthmarks. He is well known for his expertise with surgeries and management of hemangiomas, port wine stains, venous malformations, lymphatic and arterial venous malformations. And he's been in practice about 15 years. Pretty close, right?
Yeah.
About 15 years. And he's been a VBF expert for about 12 or 13 years. And we're very excited to have him. He is one of our past VBF Physicians of the Year. I see April is on. Hi, April. Happy to see you. April, make sure we're coming through loud and clear and that you can hear us and that you can see us. Just post a little note, April, so that we know that everything's coming through okay. Yeah, I see her happy face. It takes a minute or so for some people to get logged in. They nervously come to the VBF Facebook page and wait for it to pop up. There's Dennis. I see somebody, Dennis is on there. Everything is going great. Thank you, April. April's our social media director. And as I mentioned in the write-up, that this recording will be available with all of our Facebook Live sessions. Dennis Fiorino says, hi, Dr. Levitin. So you'll probably see some of your patients and friends and colleagues. They chime in every now and then. So remember, don't wait to the last minute. This is only 60 minutes long, and we're happy to take your questions. Hi, Carol. Welcome. Please post your questions for Dr. Levitin. In between, I'll remind everybody that Saturday, October 6th is our conference here, and you'll get a free clinic appointment with Dr. Levitin as well as our other experts. Free conference admission. We do not have any hotel rooms left, but we are taking names for a waiting list. We have free dental exams this year for anyone with port wine stain on the gums, orthodontic exams, psychotherapy sessions, and makeup artists. Anna Fox, welcome. So please post your questions. I'm not seeing any yet. Hi, okay. I asked in my daughter's name. Her name is Theodora. She is 6 years old. I don't know why we're not seeing it. Let's see. Oh, okay, here we go. So we have a lot of people on, and the first question is, her name is Theodora. She is 6 years old and has an AVM. It covers her throat, uvula, and cheek. So far, no treatment has been done. Let me just get back there. It's a little... So far, no treatment has been done. From the diagnostics, there is only a color Doppler.
Ultrasound.
Yeah. It showed that feeding is arterial and nidus is fed from two arteries. Our vascular doctor wants to try supraselective embolization with an occluder. Would you support his proposal or suggest something else? And they live in Siberia. So you're very... Serbia. Right. Isn't that in Eastern Europe?
A little closer.
Okay. So if we can ask, how did you cure your daughter? What treatment? I don't know if that's for you, because both of us had a daughter with a hemangioma.
Well, both of our daughters had a hemangioma, and you're asking a question about a vascular malformation. And arteriovenous malformations, as you suggested, have arterial feeders. They have abnormal connections where the artery and the veins connect, but outside of the normal vasculature, and so it tends to grow on its own rate. And certainly as the child grows, or particularly through growth phases, it may actually grow at a more rapid pace. You didn't mention any types of bleeding or swelling. You mentioned some of the areas involved. And so just before we talk about treatment, let's talk about the workup. What we want to do first is confirm the diagnosis is correct. It sounds like you're involved with an interventional radiologist who's looked at this. An MRI, which is a type of X-ray with contrast, will show the full extent and involvement of the malformation, what areas are involved, and then we really want to talk about is what kind of problems are we having? Is this a functional problem? Is it affecting their swallowing? Is it a bleeding problem? Sometimes when they involve the gums or the lining of the mouth, they can cause bleeding with just normal eating. And then regarding the treatment, I'll just summarize, without having all the information. Yes, super selective embolization, which is where we don't want to just block the feeding arteries or clamp them, but we want to do is find that area of nidus. And that nidus has feeders, and you want to block those, but you also want to block the other side as well. I defer to my specialists, my colleagues who are interventional radiologists to say how to do it, but the idea is that you need to treat the entire nidus itself, or the components of the arteriovenous malformation, and that should be done by someone who has experience in that. And I'm happy offline to take an email to review any MRI films or pictures of the child if it's visible, to answer any other questions.
Right, and Dr. Levitin can be reached at birthmark.org/Levitin, Levitin, and our social media expert will be posting that email for him throughout this session. Katerina from Germany said that an AVM on the tongue, lip, eye, cavernous sinus, cheek, chin, clamp, jugular vein treatment in Germany. So I'm not sure what her question is, but maybe.
Well, let's talk about the tongue. So the tongue is a very vascular structure, and it can have swelling, it can have color change, it can have pain, but it's also a very easy area to treat in a combination of either laser for the surface component, which can shrink the venous component of the malformation. It can be partially resected, which means we can remove a very large segment but leave the normal tongue alone. But again, this perhaps is better off after we share some clinical photos, so I can kind of have a full understanding of the extent of the malformation, so we can really target our therapy, with the right size treatment for whatever is affecting the tongue.
Thank you. And hello to Rebecca, who is the CMTC Gallus president from Ohio. Happy that you're joining us, Rebecca. Nikki Andrews says her daughter has a capillary malformation, but her arm seems to be getting bigger than her other arm. Her other arm has a hemangioma, but is still smaller than the one with a capillary.
So this is a type of malformation condition where you have an overlying port wine stain. And over time, you're describing that the arm with the port wine stain is actually getting bigger than the other side, which means there could be a second component to the malformation, either a lymphatic malformation or a venous component, which is part of the Klippel-Trenaunay syndrome. The best way to determine that is to do an MRI to see if there's just a superficial port wine stain involving the skin, or in this case, there may be something deeper under the skin. And this would, again, our goal is to first confirm a diagnosis and then discuss treatment. At an early phase of treatment, sometimes compressive therapy with neoprene or customized sleeves for compression while we sleep. Sometimes 23 hours a day is required to keep it from progressing. You mentioned that the other arm has a hemangioma that's smaller, and I guess, again, I would certainly be glad to look at any photos to try to help determine whether there's anything to compare between the two. It is unusual to have more than one vascular birthmark, but not impossible. So we want to, again, make sure that the hemangioma we're talking about is essentially going through involution as it should over time. And again, an MRI will show the full depth of any involvement other than the overlying port wine stain. And glad to answer any other questions offline.
And again, we'll be posting his direct email through the VBF website. That will come up, and you'll see it throughout this discussion. April will be posting it. Alicia says, hello, doctor. Can an ear AVM be treated or cured if it bleeds?
So the arteriovenous malformations that involve the skin often have large dilated superficial vessels. And those vessels are the ones that grow. The actual feeding vessels deeper in the skin tend not to be the source of the bleeding, but the increased blood flow into the area dilates normal sized vessels that take away the blood. And so a superficial vessel is often an area that causes bleeding, can be treated through a combination of either topical therapy where we cauterize the vein, or sometimes through local resections if it's problematic, if it keeps bleeding. The most important thing is to avoid any dry or crust that can crack or bleed overnight. So sometimes simple wound care, such as using Aquaphor, bacitracin, or mupirocin, or Bactroban, ointments that prevent wound breakdown are often very helpful for these areas. avoiding any pressure when we sleep to make sure that that there's no pressure of a hand or a soft pillow should be used against that area to avoid any compressive issues. And then, of course, any photos would be very helpful to see the full extent of what we're talking about.
Thank you. And we just got a message from Corinne, who is one of the VBF's family liaison reps, and she said I mentioned the wrong address. So it's birthmark.org/Levitin, but April will be posting that throughout the discussion tonight, our social media director. Hi, Lindsay. She said her son is almost 2, has a large port wine stain down the back of his right leg. There's no size discrepancy whatsoever, no delay in walking. What are the odds of this turning into KTS?
Well, just by the numbers, KTS is considered a rare malformation, and port wine stains is considered a very common malformation. And typically, we see early on a size discrepancy when there's an underlying KTS. So, being that the most common part of those two malformations is port wine stain, and there is no size discrepancy, I would say it's, while not impossible, extremely unlikely. And I would not even worry about any workup at this time. Over the time as the child grows, if there's any changes in the size, and I mean significant size, then yes, it would warrant reevaluation to see if there's anything growing underneath, as malformations, while they are often present at birth, may not be apparent until the child has gone through growth phases or puberty.
Great. Dr. Delphinian, our KTS expert, says the discrepancy at birth is the discrepancy that they'll have. So if there's no discrepancy, he says it's very, very highly unlikely that there will have one, which reiterates what you just said. Jessica Null says her daughter will be 3 in October. She has a venous malformation on the inside of her left cheek. We went to Phoenix Children's Hospital in June. Both sclerotherapy and surgery were suggested, but the ENT and interventional radiologists aren't sure which procedure should be done first and at what age. How do you know when is a good time? How big is too big? Does this malformation hurt her? She never complains about it.
Sure. So venous malformations are progressive. And what that means is that they tend to grow or dilate over time, sometimes in response to stimulation like hormonal growth, sometimes to trauma, and sometimes just slowly over time. The inside of the cheek is very important because it's where we chew, and it's actually prone to injury and potential bleeding. Not catastrophic bleeding, but certainly repeated bleeding that can cause problems. It also can swell and cause pain. In fact, about 40 to 50% of patients with venous malformations, that's their primary complaint, is pain. And what you describe on the inner lining of the cheek has 2 potential components. The superficial component is on the inner lining of the cheek, and there's probably an extent that goes below that surface, causing swelling of that cheek. The treatment for this is a combination of laser and surgery to debulk the area and restore the superficial mucosa back to normal to avoid any future bleeding episodes if that's a problem. And the role of sclerotherapy is dependent upon the extent of the malformation. If it's localized to or in the superficial area, it may not be required prior to the surgery or prior to the laser therapy, as sometimes laser removes the vascular component of mucosa and makes the surgery much safer. I think in this case, it's very important to have an MRI, which shows the full extent of the malformation. And it sounds like we've seen an interventional radiologist that may have already been done. And I would be glad to review your films offline to give you a more specific opinion, and especially if you can give an additional picture of the involved area with the mouth open and a flash. I can usually see the full area that's involved, and also a passport-style photo just from the front to see if there's any swelling of the cheek. And between that and the MRI, we can usually come up with a pretty clear plan on what's necessary.
That's great. Jennifer says her daughter had 12 PDL treatments by 15 months for her V2 port wine, all without GA. We took a break and now going to try 2 to 3 more treatments before she is 2, and we go into maintenance. We are going to try without GA, general anesthesia, and with Versed. She is 20 months old. Any comments on treatments without GA and use of Versed?
So this is a common question where people ask, how to avoid a general anesthetic. I think a Versed is still an intravenous type of medication, and it still has to be monitored in a controlled setting. And sometimes it can be actually safer to undergo general anesthesia with inhalational anesthesia, where they give a breathing mask for the child to fall asleep, whereas an intravenous form of Versed is something where you don't always titrate it, or not always able to predict the titration of how sleepy or how sedated the child is. This is something that I have in my own practice when we decide to do large facial port wine stains. And I think this is a conversation that probably needs further discussion because of the risk and benefits of this. I do think that after age 6 to 9 months, it becomes more difficult to hold some children safely and comfortably for large facial lesions. And I typically tell people that look at the size of the palm of the hand. That's pretty much the area that can be quickly and comfortably treated without general anesthesia. And for areas that are larger than the palm of the hand of the child, I think those are warranted for general anesthetics because the anesthetic has been proven to be very safe. It has also been proven to be very short acting, and it also keeps the child calm and comfortable. And this is really a discussion and a relationship that you have with your treating surgeon, and I think that's something that is certainly worth asking further. In my personal experience, I found more comfort and safety in general anesthetics with my team of pediatric specialists, but I'm sure in the right hands, a titration of Versed can be equally effective, but certainly not my particular comfort.
Okay, we have 40-some people in queue, so we got to get through these.
We'll
Lisa says, my 19-month-old has a large hemangioma on his left upper arm. We applied timolol drops for a year with mild changes. I have met with plastic surgeons at the Children's of Philadelphia, and they would like to schedule surgery to remove the hemangioma. I was wondering if you would recommend any other treatments prior to surgery, and if you think there is an ideal age to perform surgery. We live in Naples, Florida. Thanks.
Well, a picture's worth 1,000 words, and so if you were to email me a photo, I think I'd feel much more confident giving you the right advice. I think any hemangioma that's not showing signs of involution, that's in an exposed or visible area, warrants consideration for treatment. I think timolol is only good on very thin skin, such as eyelids, nasal tips, or ear cartilage areas. I don't think that timolol has the ability to reverse those changes, and I think that the alternative to timolol, which is oral propranolol, should only be really used in the growth phase. It's really not as effective after age 1. And so at your age, I think you're at the right age before the child becomes social to consider surgery. And I would welcome a chance just to look at your child's picture and offer more definitive advice.
And also we have one of the VBF teams down in Florida at the Children's Hospital at Nicholas, and they would also, it might be closer for you because you're in Naples, to at least get their opinion about it. And it can't hurt to have multiple opinions.
Sure.
So Carrie says her 2.5-year-old son was born with lymphatic malformation in the mouth, neck, cheek area. He also has suffered eczema since birth, along with food allergies. Soon after he turned 2, we started to see blebs in his mouth, tongue. One small bleb appeared on his lips, and another spot appeared on the side under his armpit. After seeing a derm, the lesion on his side is thought to be a JXG. Is it at all possible for these to be connected? For some reason, his lymphatic system seems to be rather sensitive, and I don't know what JXG is. Do you?
I'm not sure that's a type of granuloma, juvenile exudative. It's been a long. I'm not sure.
Maybe that's right.
But let's just talk about the two different conditions. You're talking about lymphatic malformation, which often involves the oral cavity and forms blebs or bubbles. And it's a form of superficial involvement, but it's also very treatable with coblation therapy, which helps to basically shave down the superficial layer. It doesn't need to go deeper than that, but more importantly is it removes the risk of bleeding, swelling, and pain. So I highly recommend that you consider finding a pediatric otolaryngologist or a birthmark specialist who can evaluate you for that. The second issue you brought up is the atopic disease of eczema, which also associated with asthma and in general allergies. And I think a good pediatric allergist would be able to monitor you for that. I think that the lymphatic malformations are known to respond to generalized inflammation, and by definition, atopic disease carries an increased IgE component. So there may be roles for medical therapy that can help downregulate the flare-ups, both for the eczema as well as for the lymphatic malformation.
Thank you. By the way, we get this question a lot about the sirolimus cream used in conjunction with the PDL laser. And our 2 laser experts, Dr. Geronimus and Dr. Nelson, did a study with them, and they said there was no significant difference, but they're really willing to revisit it. And I don't know if you've had any experience with it.
No, I've actually, asked exactly. Dr. Geronimus and Dr. Nelson, I think, are really, leading the cutting edge of these type of treatments. I think the jury's still out. I don't think there's been some occasional times where it's shown improvements, but not always in a predictable way. And I think, as the technology continues to change, we may find the right, the right wavelength or the right treatment that may work better than our current PDL, which is considered the standard of care.
So Jessica is asking a follow-up question, and I'm not quite sure which case she was, but she said, what are the questions I should ask for the ENT and the interventional radiologist before we go forward? Oh, that's the one who was talking about which procedure to go first.
Right. And
I was
think,
told
again,
it will never totally go away. The venous malformation, is this true?
So venous malformations tend not to go away because it's hard to cure them, but we can control them. And again, it really depends on if this is a superficial where it's the lining of the mouth, if this is a deep component where there's swelling of the cheek, and also what areas are involved. And I think that, we look at surgery for the areas that can be treated safely without risk of damage to muscle, nerves, or vital structures. And interventional radiology is more helpful to get into areas that we do not want to resect, but we still want to reduce the size or swelling. So I really feel like there's probably a longer answer once all the information of the MRI and pictures are fully evaluated. I'm sorry to abbreviate the answer, but I just don't have all the clinical information I would need to give you more definitive answers.
And everyone, his email is being posted, so you can feel free to scroll through them. Ariane, this is a very good question, that your son has a venous malformation from birth, and do we have any more understanding about the causes? And I went to the ISFA conference, and I just came back from a CMTC conference in Chicago, and there are a lot of genes that are popping up for these overgrowths and these vascular anomalies. And I am working with a couple organizations and a couple biotech companies on identifying gene therapy, because they believe they have found some genes. So I don't know if you know any more than that.
ISFA reclassified a lot of the genetic components to these malformations, and that's actually on their website. It's a very exciting website, and Dr. Bly had introduced it to our last BBF conference, showing all of the different markers that have been recently added to the ISFA classification. So, and that's a website that anyone can search for, ISSBA.
Right.
And I think it would be helpful to become knowledgeable of that information and bring that to that information to a doctor who monitors those kind of things.
And I think we can actually put a link to ISFA on there because it's on our website. So it's the International Society for the Study of Vascular Anomalies.
I think it's worth also noting that the majority of venous malformations are non-genetic or random, but there are a small percentage that can be related to familial genetic components.
Right, and the ones with the very large overgrowth, they just found that PIK3CA gene, and they're coming up with some therapy on that. There's a lot of exciting things that come out, and P10. Dawn, this is a great question, because Dr. Geronimus and Dr. Nelson get it every single Facebook Live. The dangers of getting a tattoo on a port wine stain. Both of them say no, because you know why.
I mean, I'm going to defer to them for this. I mean, but
because the colors can alter the skin changes that occur with an aging port wine stain, and depending on what colors you use, then if you ever decide, because Dr. Geronimus and Dr. Nelson say 70% of all port wine stains will develop a skin change in time, so by the third or fourth decade. If that happens and you've done a tattoo, you're not going to see that skin change. And then you're going to have to try to get it removed in order to try to get the skin corrected to go back to normal. So they know people do it. A lot of people do it to hide their port wine. It's your own decision, but they don't like it, and they say no.
I would say I've seen a lot of adults with both tattoos and port wine stains. I've seen only one that had a tattoo over the port wine stain or involving part of the skin of the port wine stain. I think it also goes just to say that skin cancer occurs in all sun-exposed areas. And so I think that not only are, any potential skin change is something that needs to be able to be observed. And so just keep that in mind if you're tattooing over any area, whether it be port wine stain or pigmented changes area as well.
Great. Ashley says her 9-year-old son has a LVM in the pelvis and the left leg, currently receiving ethanol injections. He has also developed low platelets throughout. I'm so sorry. What would you generally recommend as treatment for a deep and complex lymphatic venous malformation, lymphovenous, I believe?
So again, an MRI would certainly have been done on this to show the full extent of this. And low platelets also begs the question of whether or not there's a hematologic component. Mm-hmm. And there's something called LIC and DIC, which is diffuse and a limited intravascular coagulopathy. And so a good hematologist should be evaluating all of the different bleeding markers, which are called D-dimers, as well as bleeding time, and of course the normal fibrinogen and split products. These are all the different components that determine how much usage of clotting factors are involved in the body. And so low platelets is an indicator that there may be something potentially off on the normal values of these markers, and it's not normally measured in a typical general checkup. So they have to be specific markers that are measured by a hematologist. Regarding the interventional component of this, I mean, we certainly have Dr. Robert Rosen, who we refer a lot of our extremity cases to. I think that the use of ethanol is one of many substances that are used for sclerotherapy treatments, and I think again it all depends upon the extent and areas involved, as ethanol has potential risks and benefits as do each of these substances. And so I think that is again probably a longer discussion offline.
Yeah, and the other email for Dr. Levitin at birthmarkcare.com has been posted in addition to his. Hi, I'm Tina Muscarella McGrath. That's Julia's mom, one of your favorite patients, and Melissa Scarborough. Hello, ladies. Also, you can reach me at birthmark.org/Dr. Linda. And Georgina wants to know, can anything be done about overgrowth in leg, arm, and hand? My daughter's left side is larger than the other, but not longer. She is 3 years old, and as she gets older, the bigger the left side seems to be.
So what's left outside is whether or not there is a malformation component to this, or whether or not this is hemi-body hypertrophy. Sometimes we even have hemifacial hypertrophy. It's a growth abnormality where one side of the body just grows larger than the other. At a young age, I would certainly see a geneticist and also a pediatric specialist for craniofacial to evaluate this, because these are the kind of things that really you want to find out what the underlying diagnosis is. If there's a malformation, then again, an MRI would be evaluated. Typically, you can feel for these things. But if it's normal tissue with just overgrowth, and it's not symmetrical, meaning on both sides, which have, again, other genetic causes, I think this is best evaluated by a pediatric specialist.
And by the way, Boston Children's Hospital with Dr. Denise Adams is doing a massive clinical trial right now, study on overgrowth. And most of them have a Port Weinstein, lymphatic, or a venous. And I just came from the conference in Chicago, and Dr. Drolet presented on that at that excellent CMTC OVM USA conference. So it was really great. So there is a lot going on. Alicia wants to know, one doctor here in Miami, that he will cut my ear off if it bleeds a lot. I am terrorized if this could be the case. Thanks, doctor, for your time. I am in Miami. So that's Alicia Maria, but you said you would look at her imaging.
Yeah, I would like to see what the ear looks like, and I would say any amputation would be considered the last resort, whether it be toes, fingers, extremities, or ears. We want to try to maximize our potential treatments for medical therapy, therapy, for even limited surgical therapy, anything to save the organ. That would be, again, our last option.
Okay, so Ashley just added that her son was diagnosed with KTS, and the doctors haven't agreed on that. That's very common, again, from this conference. A lot of the kids with the cutis mamarata, telangiectasia, have KTS, or now they're calling them cloves, and they're going back and forth, and the parents are saying, is it cloves, is it KTS? And the doctors are saying, let's just get the management of it right.
So we're really talking about, tomato, I mean, do they have enough checklists to create a KTS or a different syndrome called cloves? And I would say that that's the most important thing, is to recognize that the medical management, and which is compressive therapy and treating any superficial involvement to minimize any skin changes, is really just the critical evaluation early on.
Annie has a couple questions. Annie Beats. She wants to know the connection, which there is, with the lymphatic malformation, flare-ups, and being sick. Is it true that ibuprofen is not good for a lymphatic malformation? And why do you sometimes require steroids when sick to bring down the lymphatic malformation? Do you always treat a kid with a lymphatic malformation with ABX when they have a temperature?
It's antibiotics.
Right. And does a lymphatic malformation affect immune system? I feel like my baby gets every virus. Difference between different agents used during scleral? Is it based on diagnosis. My child got bleo and doxy. Well, lots of questions. For
Let's
lymphatic affecting the tongue, is a TR surgery a given, or can sterile take care of it? So you get the picture.
I get the picture. So a growing child has potential for increased growth or flare-ups of the lymphatic malformation, but also anything that causes an infection in the body, even in a different part of the body, can cause the localized area of lymphatic malformation to flare up. And in my experience, being aggressive with medical therapy can minimize the growth potential of these lymphatic malformations. And so while sometimes does a fever indicate that you should treat it, I would say is any signs of swelling, warmth, or redness of the overlying skin, bleeding episodes, or increased bloody vasculature to the mucosal component of the malformation warrants the consideration of both an antibiotic course and a steroid course. And usually we're talking about 5 to 7 days therapy, maybe up to 10 days, depending upon the severity. There is some merit to nipping it in the bud, which means that the earlier the start, the better. You can usually minimize the length of time on these therapies. And it's not uncommon for 2 to 4 times a year for some of my patients with lymphatic malformations who are anywhere from age 2 to 6, and even up to age 8 to 12 to have flare-ups from these type of things. And I think it's part of living in our environment. We keep Purell in our house just for good hygiene. I think these kids have to be even extra careful about washing their hands, avoiding contact to public areas without washing their hands frequently, avoiding touching their hands to their face and their lips, which is something that everyone does all the time inadvertently. And I think that's the most important part of is the prevention for these type of infections. Certainly, again, we've Dr. Out in Seattle, just escaped me.
Wayne Yates?
Out in Seattle.
Jonathan Perkins?
Perkins, has done a lot of research on the inflammatory components of lymphatic malformations, and we're still trying to work on understanding that better. And as far as sclerotherapy, you mentioned bleomycin and doxycycline, which are two of the most common. But sclerotherapy is not a home run type of treatment for lymphatic malformations. It's a stabilizing in most cases, although occasionally can cause shrinkage as well. And again, these are treatments for areas that are difficult to reach or not able to be treated, whereas a lot of the superficial components or the reachable areas are very treatable by laser therapy or coblation therapy, or even targeted surgery if there's a particular area involved. And again, prior to any of these treatments, we often get an MRI to see the full extent of the malformation. And again, that would certainly be warranted in this case.
Okay, so we're halfway through our session, and we've had an amazing and alarming amount of questions. It's really surprising. I'm really happy. Amanda Bayer said she's 38 years old. She has a port wine stain on her left hand. She occasionally gets tiny red pinpoint-sized bumps, and they feel like splinters on my birthmark. They eventually go away, but a scar remains. What is this, and is something I should worry about?
Well, this sounds like a flare-up of some sorts. Port wine stains gradually go through sometimes hypertrophic growth where they grow, even blebs or cobblestones in the involvement. They don't go away. Once they grow, they stay there. So something like this sounds like a dermatologic kind of condition, perhaps a pyogenic granuloma from a localized trauma. But something that comes and goes and leaves a scar is a little bit unusual.
Yeah, or little angiokeratomas, little pyogenic granulomas.
Well, again, sometimes a scratch can create a little blood tumor, like I call it, a pyogenic granuloma, sometimes a tufted angioma if it doesn't go away. But a localized, maybe even when it flares up, getting a biopsy with your local dermatologist or surgeon would be helpful to get a diagnosis.
And any pictures that anybody has that they want any of our doctors to see, they can send them to me at birthmark.org/Dr. Linda or through the VBF website, and we will get them to the appropriate people. Hi, Corinne. She's checking in from Seattle. She had an accident the other day and ended up with a concussion. So we're trying to tell her to take it easy, lady. We need you.
Sure,
we're praying for you to get better. Melissa said her granddaughter was born with an intraorbital hemangioma. She's been on propranolol since 3 months, just turned 2 years old, about to begin weaning her off. Should we have an MRI? Yes. She should be put to sleep or just watch her for signs. She's in South Alabama, been followed by a pediatric ophthalmologist. It's so concerning.
So the two things I would tell you is that a ocular hemangioma that does not have any skin changes should have been evaluated by an MRI early on. and would be followed by an MRI later to see about the response. Typically, hemangiomas grow up through the first year of life. So typical treatment parameters for propranolol is usually for up to 9 to 12 months of age, and then typically weaned soon after. During this time, a pediatric ophthalmologist would be measuring for any signs of astigmatism, which means that the hemangioma growing inside the orbit would be causing any pressure on the eye. And there's no mention of those measurements, but as those measurements are back to normal, then absolutely that would be the time to wean off the medication. The most important thing here is we are assuming the diagnosis was a hemangioma, and a MRI is a very helpful scan to confirm a diagnosis because there's a very lobulated classic appearance of the hemangioma on an MRI. There are other types of lesions that can occur inside the ocular, the eye, and so I would only warrant the idea that a MRI should be repeated, and I would say good things go away, and anything else that persists should be evaluated by a ocular surgeon or oculoplastic surgeon to evaluate whether any biopsy would be warranted at this time.
And you can get a free opinion from Dr. Aaron Fay. He is the leading vascular anomalies orbital expert in the world. That's at birthmark.org/Fay, F-A-Y. Also, you can email me and I can forward it to him. Jacqueline says that, how does puberty affect the vascular malformation in girls? My daughter has one near her hand.
Hard palate.
Her hard palate.
Yeah.
Oh, yes. And we're wondering.
So, again, we don't have a diagnosis here. And so what I would say in this case, if it's a port wine stain that has persisted on the palate, it's unlikely to grow significantly because mucosal areas tend to grow much slower than the cutaneous or skin areas. If it's a residual hemangioma, which is part of a segmental distribution, those gradually fade away over time. Again, getting the diagnosis correct is the most important. I think vascular malformations in general are prone to increase in size during pubertal growth. So a lot of times we target our therapy before that to try to minimize the residual bulk of disease. So there's literally just not much left to grow. So I think that's something we'll have to, again, get a little more information on to give you some more information.
And again, send all your inquiries and images and any records to Dr. Levitin through birthmark.care or through birthmark.org. Wesley says he's from New York, and can an AVM become a venous malformation?
So no, the very nature of a diagnosis of a arteriovenous malformation is very different than the pathology of a venous malformation. Once again, getting the diagnosis correct is the most important thing. And if you've had a MRI, that should clearly define the venous malformation, which has classic phleboliths or fallouts of where some of these calcifications occur. Also, the area involved, and any clinical photos can often define the type of malformation right off the bat. So again, happy to help you confirm your diagnosis. I'm also in New York if you need me, and let me know if you have any problems.
I'm sorry, I'm missing some. Hi, Carla. She's watching. Hi. So Amanda says she just wanted to say thank you to VBF. We've got a lot coming in. No funding for laser treatment anymore in UK. Listen, Stephen, I am working with an expert with the lasers in Italy and in Greece right now. We are trying to get lasers into the UK, but email me because we're working with somebody right now that we're trying to get in either Ireland or Scotland, but it's been really hard. I mean, very difficult.
That's striking to me because we consider treatment for birthmarks to be a reconstructive procedure. Anything that was born and turns into an abnormal event, any correction of an abnormal event is returning back to normal. That is not a cosmetic procedure. That is a reconstructive procedure, no different than any kind of trauma or infection or any other destruction of normal tissue.
Thank you.
It's very important to highlight the importance that these are not cosmetic procedures, but are part of the plastic and reconstructive procedures that we perform all the time, from birth with cleft lip, cleft palate, to other craniofacial deformities, or any reconstructive event after any type of trauma or surgery.
Thank you. Carrie says JXG is the juvenile xanth. Yeah. Okay. So there's, okay, Orit, hi from Israel. Hi, Orit. Can you please explain why a port wine stain shouldn't be exposed to the sun?
Well, I think what happens is that it darkens more than it normally would otherwise. And so it's really part of the prevention of the darkening effect that happens over time, just from even walking through your day, traveling, shopping, and walking indoors and outdoors. So I think daily sunscreen and hats, any prolonged exposure is important. Otherwise, you're prolonging the type of laser treatments that's required to reverse these darkening changes if necessary.
And our next Facebook Live is September 5th or 6th. It'll be announced with Dr. Geronimus, and he's going to cover all about sunscreens and covering.
Good.
So Paula says that her 8-month-old has a segmental hemangioma in her left arm. What type of treatment do you recommend? Do you only focus on laser or other treatments?
So at 8 months of age, this is a prime period of time to consider oral propranolol therapy. It's very and highly effective on segmental distribution hemangiomas. It's not effective on 100%, but it's very, very effective, 60% or more. And in addition, the concurrent use of laser therapy while on that therapy actually reduces the overall length of treatment for both the laser and the medical therapy. So I think it's not either or. It's at this point likely the benefit of both treatments would be highly beneficial to this child.
Thank you. So Nate and Jamie Gamel say hi to Dr. Levitin from Nebraska. They said he was their son's saving grace. It's nice to hear those. Stephen Booth says, do you believe you will ever find a complete cure to totally cure port wine stains in the future?
I think that is the mission of Dr. Nelson and the entire Beckman Laser Institute.
Yes.
They are constantly coming up with new recipes and new lasers and new combinations. So
well, and Dr. Comey found the gene,
Yep.
And so now that they found the gene, the next step is a therapy.
Wouldn't that be something?
Yes.
Hopefully in our lifetime.
Yes.
That would be a wonderful thing.
Yep. So Paula says that her daughter is 8 months old and has a segmental hemangioma. Her daughter's hemangioma is slowly growing in thickness, and
Maybe the same child. So yes.
well, no, the Children's Hospital of LA maybe has
It's an
recommended
8-month-old
to
with
start.
segmental.
Okay, what is your take on this treatment? Is it
100%.
safe?
It's safe and effective for segmental distributions, and it should be treated, at the stepwise up to a maximum of 3 milligrams per kilogram per day, divided into 2 doses, which is half a dose in the morning, half a dose in the afternoon. Always with propranolol, you want to give food before the delivery of the medication, and then again give food 2 or 3 hours later. And in those cases that I've treated, and it's been almost 10 years now, I've never had anyone who had low blood sugar. And by dividing into twice a day doses for ages 6 weeks and older, we've never had any bradycardias or anything like that. So it should be monitored by someone who's comfortable, administering the medication. But at 8 months, this is a great window of time. Certainly, the earlier the better for these type of cases.
So, and you mentioned that you want to come to the conference, but you don't want the laser treatment, which is fine. But if you want to email me directly and you want me to try to coordinate if there is a potential for treatment with Dr. Levitin while you're at the conference, we might be able to work something around the Friday before the conference
Absolutely.
or the Monday after. How can I protect my baby's tongue from the sun? It's under her tongue and floor of mouth.
So that is not necessary to protect the tongue from the sun. It's really the lymphatic malformation, and treating it with bleo, it looks like you've already had treatment. But again, the superficial vesicles are very easy to treat with coblation therapy, which shaves it down. These are the classic areas that tend to progress over time. And I think the most important thing is to remove any malformations from under the tongue in the floor mouth area, as that's where it can cause a lot of changes in the mandibular shape and structure as the child grows. So again, there's a window of opportunity early on to treat these aggressively, reduce any swellings. It sounds like you're already seeing a good intervention radiologist who's very on top of this, and I wish you a lot of good luck.
So this question comes up a lot, like at what point can you laser a hemangioma, and then when do you switch to a drug or surgery?
So I think, regarding the age of a child, hemangiomas occur in the first few weeks of life. They're typically born with normal skin that has gone through a change in the first several weeks. And I think that laser therapy is always indicated for the superficial component of hemangiomas. The earlier, the better. Once a hemangioma grows a deeper component where it rises up more than 2 or 3 millimeters, the laser becomes less effective of reducing that size, and that's where oral propranolol can help slow down, even stop the growth, and in some cases even reverse the growth. And again, during those first 6 to 9 months of age, it's very important to implement propranolol therapy in a combination with laser therapy. After 9 months of age, we reevaluate to see how effective those medical and laser therapies were, and try to help determine which children will benefit from potential surgery for debulking if those treatments were not sufficient. and which ones need additional therapy or longer therapy to try to avoid potential surgery. But certainly by 9 to 12 months of age, certainly by 18 months of age, we should have a clear understanding or idea of who would benefit from early surgery intervention, who would benefit from more laser therapy, and hopefully by then we're weaned off propranolol as well.
So there's so many questions coming in. We're missing a few, but somebody wanted to know about treating KTS ulcers.
Yes.
So
KTS ulcers essentially is wound therapy, just like any diabetic would, which is basically venous insufficiency. And I actually have an ulcer instruction manual that's posted on the VBF that we can find the link to, and we'll set up afterwards. But basically, you want to do extremely good wound care. You want to keep it clean. Sometimes there's something called Elta MD Scar Gel, which is a silver-based gel to prevent infections. You want to treat oral antibiotics if necessary because infected wounds won't heal. And then you often require a wound care specialist to do wet to dry dressing changes to form healing. It's very important to elevate those extremities to get rid of any venous insufficiency or venous congestion. And it is a long-term therapy. It does not does not heal quickly or overnight.
Thank you. Some questions are missed, so resend them through if we don't answer because we only have 15 minutes. Chris says that she has had an MRI done. 2 radiology imaging specialists told she had a fibroadipose vascular anomaly. The surgeon said she had a deep hemangioma. How do I know who is right? She lives in Romania and she's in a lot of pain.
Yeah, I think an MRI would be the film that would need to be seen, and I certainly would be glad to help look at this. But also, Dr. Robert Rosen is our extremity specialist who sees a lot of these. This could be misdiagnosed. This could be a venous malformation in the superficial compartment of the fat and muscle. Pain, by definition, sounds like it may be in the deeper part of the muscle. But again, we would need to see a clinical study, MRI with contrast to fully evaluate that.
Great, thank you. Tara says she's a 46-year-old female with a port wine stain covering 65% of her right side, including face, neck, torso, and leg. She's been through PDL with little results over a 5-year period. She gave up due to the stress-related and recovery time. Is there anything better?
So I would say that this is a very difficult situation where you're describing such a large area of treatment, and that port wine stains on the extremities and torso do less well than the face and neck. And when you're trying to potentially do laser therapy, you're trying to lighten or cover the stain. And in this case, there's something called microskin out there. Dr. Geronimo has brought it to New York, and it's basically a color match to your normal skin with a spray-on, breathable, washable makeup. And I think for someone with that large of an area, I think it cost-effective, and also for your comfort, microskin is something that you should consider and look up after online about this.
So Barbara just says thank you. The Saintos said thank you to her. Chastity said that her sister and I both have lymphatic malformations. Hers is on her thigh. She has these small lesions that look transparent and fluid, the little blebs, and can cause her pain and make it difficult. Is there anything she could do for them? Yeah,
so this is superficial or skin involvement with lymphatic malformations, which form these little vesicles. And unfortunately, what you do is you have to trade off creating a localized scar in place of these vesicles. But by using coblation in a selective area and aggressive wound care afterwards, you can sometimes get to the base of these vesicles, and then things heal with a controlled scar. So it's a flesh-colored area, but no more vesicles and no more pain. Again, an MRI would need to be seen first to make sure there's nothing feeding this from underneath. But this is, again, a superficial type of treatment that can be very effective.
So Jane Sikowski-Bell asked the same question about the sirolimus with the port wines. And like I said, Dr. Nelson and Dr. Geronimus haven't seen a big difference, but they're going to re-examine it. Carrie wants to know, is it recommended to wait on treatment of a lymphatic if it's swelling or causing any issues? It's grown but is stable, Carrie said.
Well, again, you're really asking a large opening question is like when to treat. And I think the most important thing is to fully evaluate with an MRI the full extent of the malformation, and then you really determine if there's any symptoms. I think sometimes there's pain involved in growing malformations, and then sometimes, depending upon the area involved, which we don't, is not clear in your question, an ounce of prevention. Sometimes we want to debulk these areas because it reduces the potential growth in the future. So sometimes we do small surgeries early on to try to minimize the potential growth in the future that could potentially need more invasive therapy. So again, that's a two-pronged answer, basically saying if it's not causing any problems and it's very small and limited, then the observation is fine. If it is involved in areas that have the potential to grow, that would need to be, a longer conversation about the potential benefits of treatment early on.
So Jennifer says she has a newborn with a hemangioma covering her entire hand, arm, and chest, and she didn't finish it. She said they saw a cardiologist. I am concerned that she said it was newborn, it was there, that whether it's a port wine or a hemangioma.
I think, again,
so maybe she can just send you pictures.
I would send photos and pictures, and again, the most important thing for these type of early cases is getting the diagnosis correct, because the treatment options are different. And if this is on the chest and arm, it may be a port wine stain, or it may be an unusual type of hemangioma that started off early. And again, for that large distribution called segmental, if it is a hemangioma, oral propranolol is highly effective. But however, we treat this at 5 weeks of age and older as an outpatient or inpatient sooner. And so again, seeing a pediatric dermatologist, a pediatric otolaryngologist, or a birthmark specialist would be important at this early age. And again, the earlier the better.
Great, thank you. And Carla, we've been doing Facebook Live sessions since January 2017. All of them are on our Facebook page, and anyone can access them at any time to review what our doctors say. Just want you to know you can have access. Joe says her son was born with glomovenous malformation. He's 18 years old now, lives in the UK. He has a large malformation on his elbow and the smaller blue-black lesions on other areas. He would really like to know what is best, most effective treatment. Also, is there any pre-genetic? I like to mention that, especially since they are in the UK, that this was brought up at ISFA and at our conference in Italy. And Dr. Mika Bicula from Brussels is studying this. So Joe Morgan, email me, because I'd like you to get in touch with him in Brussels. He is doing the cutting edge genetic testing on these lymphatic malformations in Europe.
And then just quickly, glomovenous malformations is a superficial component, a superficial involvement of venous malformation. Sometimes you can get discrete areas of pain from areas that get blocked or clotted. And so the treatment for glomovenous malformations may be laser therapy with YAG laser just for the superficial purple color. These can be very diffusely purple and disfiguring in that component, or even just localized surgery to remove those blocked or clotted vessels called phleboliths. And then for my patients who have full extremity glomovenous, we just basically try to minimize any surgery for just those localized areas. You cannot cure this, and treat any superficial areas that are discretely purple or blebbed. Will reduce significantly with gentle YAG laser therapy.
So Danielle Lipsky is giving a shout out to you that you were Lena's doctor, and that's really nice. Again, the emails are here. Melissa says her son has a hemangioma on the underside of his top lip. What age should surgery be considered? We're being treated with propranolol for 4 months. It hasn't shrunk, but it's slowing the growth. Also, does the sun affect the hemangioma?
Yeah, so a sun will not grow a hemangioma. Certainly, for a newborn, you want to minimize sun exposure because their melanin or pigment has not thickened up yet, so they're more sensitive to sun exposure. Hemangiomas that are focal or discrete are less sensitive to oral propranolol. I think by 4 months of age, if you're not getting the full response of propranolol, longer may not be better, and it may be reasonable to wean off at an earlier time because it may not be offering much benefit. If there's a superficial component, then laser therapy may be helpful, but areas on the nose, the lips, and the ears that cause large swelling tend not to resolve on their own. So actually the lip hemangiomas, nasal tip hemangiomas are most likely the ones that may need surgical correction for this. And so yes, we do consider early surgery after 6 months of age when it's clear that the growth has finished and that it's obvious that this is not one that would involute or go away on its own. And again, without a picture, I'd be glad, if you send a picture, I'd be glad to offer some further advice.
So Melissa said that it was confirmed by MRI at 3 months. So that was the one that we questioned.
Oh, good. So.
Kiana's hi Kiana from Trinidad. Persons with large port wine stains who receive trauma to their birthmark by accident, what is the best course to inform doctors treating who are unfamiliar? So she's getting all her treatments here in New York. So
she's asking is, if you have port wine stain and let's say you cut with glass or have a car accident, what would you advise the treating surgeon? I would say is these are venular malformations, which means that they do not bleed like an arterial bleed, like a arteriovenous malformation. They may ooze more, they may bleed more, but first thing you do if you ever cut yourself is you put compression on it with a cloth, and that this would be something that can be treated like normal skin. It may need a little more cautery or a little medicine like Surgiflow or Flow Seal to stop the bleeding in an acute setting, but typically compressive therapy, compression for 5 to 10 minutes should stop most bleeding. And then stitches would be the normal thing for any trauma of the skin.
Sean just said we're from the UK. Any advice? I'm not sure what that message was regarding. If that was the one that was trying to get the port wine stain, the treatment.
I think getting laser therapy in the UK, I'd say that there's a enormous amount of support to recognize these as congenital malformations, as things that are not cosmetic. And certainly the American Academy of Dermatology, the American Academy of Otolaryngology, the American Society of Pediatric Otolaryngologists, and the American Academy of Pediatrics have, in the United States, have all recognized this as the proper and necessary treatment, which is pulse dye laser for port wine stains.
And I'm working with the AAP and Dr. Buddy Cohen out of Johns Hopkins right now for the first ever guidelines on treating infantile port wine stains with a laser. Yeah. Tara mentioned she has a shunt implant in place to regulate pressure, and it's been successful since 1999. We're winding down. We only have 5 minutes left, which is fine.
A few more in there.
Advice for MCM laser treatment. So that's the
cutis marmorata.
Yeah, it may be the cutis marmorata or capillary, multifocal capillary malformation.
Again, send a photo, and getting the diagnosis correct. The same laser is not treated for the same malformation. That's so if you go see one doctor who has one laser, they may not be able to treat you. You have to be able to have a variety of lasers in case, depending upon the diagnosis.
Oh, this is a really good one. Jennifer Michael Swanson, they had a child who had a hemangioma, and there were no medications were available, they said, for them years ago. And it's on the chin and shoulder area. So what are the options now that that child is a teenager?
Well, again, not having a photo, I'd want to know what exactly is the problem. If it's residual vascular staining, is that what they're?
It may be the redundant tissue. It may be. But
exactly. So there's again, the real question is what do you do with hemangiomas that don't go away? When people say hemangiomas go away, they don't go away. They just slowly fade and they shrink. But in certain areas above the neck area, there's really nowhere else from the fade or shrink. And so in these cases, these are patients who have either residual soft tissue or residual vascular stain. And the same laser we treat with babies, we treat with adults. And so you can get rid of a lot of the vascular stain with pulse dye laser. And you can also do small and targeted surgical therapy to remove or debulk the excess tissue that may still be behind from a large hemangioma.
Yep. Kara Stotler, the 45-year-old with the VM lymphatic malformation, entire side of body, treated by Dr. Ortiz with Bleo, treated also a few times by Dr. Rosen. Again, Boston Children's has that overgrowth study going on right now that are having some dramatic results. It might be worth, checking out that study. Hello to the Browns. And lots of, I don't know what these are, happy faces. I guess everybody's happy. The next session will be in September. Sarah says her 2-year-old was born with a venous malformation on her back. Ultrasound concluded it has no deep components. They're not treating at this point. Should they expect her to eventually have pain, or is there a possibility it can remain pain-free?
It really all depends upon the depth of the malformation, and at some point it may be helpful to get a MRI. And the MRI will again show the full extent if it's contained within the skin and fat, or if it's involving the muscle underneath. And it's also a good way to measure or compare in the future. Right now, there doesn't sound like there needs to be any treatment if it's not bothering them, but it may grow in the future. And again, the MRI is also a good way to confirm the diagnosis. An ultrasound kind of shows the blood flow in and out, but an MRI is by far much more sensitive and specific.
And hello to Paula Miltenberger. She's saying hi to us, so it's great. Well. Hello, everybody. We have less than a minute. Wesley said his first treatment lasted 6 years. After last year, I have been treated twice. What can cause a VM to continue to grow that fast after a long period without it? Thanks very much for your time.
A fast-growing VM may have an underlying arterial component if it's growing faster, or if you're going through pubertal growth. Again, reevaluating to get the diagnosis correct, an MRI with contrast to show what the full extent of the area. Sometimes getting a biopsy of the area. It sounds like maybe you've had some interventional sclerotherapy or embolization, but those are two potential things to confirm the diagnosis, get a new MRI, and see what's going on.
And Carrie Pratelos, who keeps, I know you keep trying to send your message, please email me, and I want to put you in touch with Dr. Drolet or Dr. Adams about the complex lymphatic malformation condition your son has. I'd like one of them to speak with you. Allison says, a statement, you should share some information on using liposuction to remove the birthmark from great addition to the laser Dr. Levitin took my lifelong treatments to another level.
Yeah, so basically you want to find the right size hammer to the right size nail. And sometimes the tissue overgrowth, you don't want to do surgery, you just want to deflate or remove the fat layer. And so using liposuction can target just the fat layer of the face and the neck and get a nice 15 or 20% reduction, no scars, and it can make a world of difference creating symmetry and contour for port wine stain overgrowth.
So Allie wanted to know if laser is effective for the MCM, the capillary malformations. I guess
Pulsed
you have
laser
to
would
see.
be, if it's vascular, absolutely.
One more question. The best treatment recommended for glomovenous, please. I have an 18-year-old son who has had surgery. It was elbow, I think.
I think they resent that, yeah.
Okay,
we talked about that in the
send
UK, yeah.
And we've seen, Ian, if you still have time, what are the difference in venous versus lymphatic versus mixed?
So that's really the diagnosis of whether or not it contains just lymphatic components, venous components, or has both components. It doesn't really change the outcome. Mainly, you're going to treat the targeted areas depending upon the area involved with either surgery or sclerotherapy. And just, again, depends upon what's involved.
Okay, Adrian, I'll answer that last question. According to Dr. Nelson and Dr. Geronimus, you've reached maximum clearance with your port wine stain at the moment. When 2 subsequent treatments yields no further clearance, then you need to take the break. Okay. All right, everyone. Well, we'd like to thank you. You can send your additional questions to Dr. Levitin. His email is posted, or to me. If you need any other additional questions answered, just post them here to our Facebook page. And remember, you can go back and review all of our Facebook Live sessions with all of our experts at any time. Thank you, Dr. Levitin, for a very informative session. Thank you all.